As you probably know, I talked about cardiac surgery, acute kidney injury on Wednesday, and what my plan is to move forward and now focus on new technology, which is so important. So you'll see some slides that I have used. Here are the disclosures. This is my perspective. So risk factors, we highlighted those before, and as you know, these are well-recognized risk factors. There have been important studies, this is from Milan, that looked at the incidence and risk in 5,000 cardiac surgery patients, and as you know, they documented well the risk of acute renal failure in 41% and 64% required renal replacement therapy. So this is the mortality, and it's a real challenge to address that. And then there's the multivariate analysis, and we also highlighted that. What's important here is the blood transfusion, creatinine, emergency surgery, low ejection fraction, need for reoperation, mitral valve disease, and of course for renal replacement therapy, very similar risk factors. And then we spoke about the importance of hemodynamic instability and fluid overload, increasing the risk of acute kidney injury. And this study by Hayes and Felix was very important in highlighting that. And as you know, they made the point that the use of norepinephrine, LVAD, a high dose, a low mean arterial pressure, and milrinone, all associated with cardiac surgery-associated AKI. Now, this slide may seem out of place to you, but in fact, I wanted to make the point that we talk about risk of AKI, and I think one of the important factors in causing AKI is the occurrence of cardiac tamponade. And so I think as part of this presentation, I thought I ought at least say that's an important risk, and I'm not sure that we all look for it. Now, as a surgeon, I always am taught to look for it. You know, something going on that I don't know about or didn't anticipate. But in the intensive care unit, it's not the first thing maybe when things don't look right. So what is the physiology of cardiac tamponade? Well, it's a decrease in the transcardiac pressure gradient. There's inadequate filling of the heart, decreased stroke volume, and of course you get the sympathetic activation, and then you have hemodynamic collapse. What is the setting? And that's important, that as we looked at cardiac tamponade, what is the setting? High chest tube output, a sudden decrease, coagulopathy, decreased responsiveness to the inotropes and the vasopressors, and refractory hypotension. The diagnosis is not always obvious. You know, we're taught there should be an equalization of atrial pressures. Well, that's not the case in cardiac surgery because the pericardium is often left open, and there can be blood accumulated posteriorly and not anteriorly. So we have to use the X-ray, we use echo, diastolic collapse, but the main thing is anticipating it as a problem, and the treatment is maintain the preload because, again, the problem is inadequate cardiac filling. Inotropic support is needed, extracting chest tube clots, and then re-exploration, if necessary, in the intensive care unit. Now, also, ventricular assist devices are a risk factor. We're talking about risk assessment and new technology. Very clear that there's an important risk, and there's a paper that came out from here that demonstrated that. And, you know, the LVAD is very common now in cardiac surgery, especially patients who have had an acute MI and in the cath lab are in cardiogenic shock. And then, as you know, ECMO is an important risk factor as well. And again, we have a paper coming out from Vicenza regarding this. Well, early diagnosis is a continuing challenge, and we have talked about that here in many ways. And we've talked about the fact that serum creatinine is just not a very helpful diagnosis for the early diagnosis of situations that are causing acute kidney injury. Yes, it often is up 48 hours afterward, but by then the injury has occurred. So late recognition is a major issue, and that's where our focus on technology comes. As you know, biomarkers are very important, and we've talked about the importance of biomarkers. Here's the from ADQI 10, the consensus conference. And you know they're functional biomarkers and damage biomarkers. The point is that, as you know, NGAL and these others have been a focus for detecting acute kidney injury, but very interestingly, NGAL is not perfect. We've known that, but an important part of this is that, and I might say, one of the beauties of it is we can detect acute kidney injury 2 hours after injury, so it does provide a means to institute therapeutic changes, but it's not specific. And there is, and this is an important point that I've become aware of, there's a loss of value in patients with chronic kidney disease. In fact, there's a very good paper that makes this point. I just pointed out to you, you may want to look at it, by Milkelroy, and it points out the effect of baseline renal function on the effectiveness of NGAL in detecting acute kidney injury. Well, we focus on the cell cycle arrest biomarkers as being so important as a new means to detect acute kidney injury measured in the urine. And there are multi-center studies that show that. And as you know, here's a paper from Mirsch and colleagues about how effective it is. And, you know, the main point is that it's very helpful in predicting AKI early after cardiac surgery, and this is an excellent article to suggest that. So what are the recommendations for monitoring the biomarkers then? Well, our approach has been, and I can't say we all do it, but I think a very reasonable approach is for all cases, they should all have, of course, a serum creatinine pre-op, and then every 24 hours. I think NGAL and cell cycle arrest biomarkers should be taken preoperatively to know if there is ongoing acute kidney injury. And then, in high-risk cases, and I'll define that in a moment, there should be sequential measurements of biomarkers during the first 24 hours and beyond as needed. Now, what are the high-risk cases? Well, high-risk cases are those with an estimated GFR less than 60, ejection fraction less than 35%, emergency surgery, cardiogenic shock, acute MI in the week preceding surgery, left main coronary disease, on diuretic therapy or inotropic therapy for decompensated congestive heart failure, and cardiopulmonary bypass duration of greater than 3 hours. And as we've talked about, and it's so important to keep in mind, every patient is a unique individual with unique hemodynamic requirements. So how do we know what are the hemodynamic requirements of a patient? And that's where the new technology comes in. We now have a way to look at the lower limit of cerebral autoregulation, and we can use a near-infrared spectroscopy as a means to study the cerebral circulation. This is the type of device. It's non-invasive, and you can see that it gives a good estimate of blood volume. And we do have a study that came out that shows that blood pressure excursions below the cerebral autoregulation threshold during cardiac surgery, this is on cardiopulmonary bypass, are associated with risk for AKI. And that was an important finding. And among the findings was that when the urine flow was low after cardiopulmonary bypass, in fact, there was an important risk of AKI. So urine flow also is a valuable parameter. Now, cardiac surgery today, there are confounding factors that I have mentioned, and just to point out that we're trying to avoid blood transfusions. But when we do, there's a need for vasopressors. And then the question is, are they constricting the renal vasculature? Is the kidney adequately perfused? So what criteria in real time do we have to determine the optimal balance of hemoglobin level and vasopressors? Well, I pointed this out. Dr. Ranucci and his colleagues have done important work in Milan, and their studies, they actually have a goal-directed protocol that they have implemented in 2 periods of time. And using that goal-directed protocol, they have reduced their incidence of AKI. And you'll notice there's an important relationship to hematocrit and AKI. So if the hematocrit is, let's say, less than 20, you can see the risk of AKI is tremendously increased. But with their new protocol, there is at least an improvement in results. So what are their findings? Their goal-directed protocol is an adequate hematocrit during cardiopulmonary bypass, adequate flow. And so you say, well, what is adequate? Well, they define that by talking about oxygen delivery, because after all, if you know the hemoglobin, you know the O2 sat, and you know the flow, you can determine what oxygen delivery is. And based on their data, they believe that the minimum should be 272 ml per minute per meter squared. Their results are important. Using their protocol, they have reduced their incidence of AKI from 5.8 to 3.1%. So new protocols are having an effect. We used a similar protocol. We appreciated the thought behind Dr. Ranucci's study, he and his colleagues, and we have a oxygen delivery measurement that we looked at. The lowest O2 delivery on cardiopulmonary bypass that predicted AKI was a 225 ml O2 per minute per meter squared. In other words, if we didn't deliver that amount of oxygen on cardiopulmonary bypass, then AKI occurred. The p-value was 0.01. And the other point was blood pressure was very important. If the mean arterial pressure was less than 60 millimeters mercury for more than 15 minutes, then again, there was a high risk of AKI. So oxygen delivery seems to be a very important point. And the question is it a useful guide when we have patients in the operating room not on cardiopulmonary bypass or in the intensive care unit? And that's the question that we still need to address. Well, another fundamental issue in looking at patients postoperatively, and we've talked about the importance of urine output. I was so impressed with the importance also this morning in pediatrics patients and in neonates, but it's important for all our patients. And the issue is we are not able to directly measure renal blood flow at this point. Maybe someday we will, but we are not able to do it, at least non-invasively. But urine output is a surrogate for renal blood flow. And so we have done a study defining oliguria during cardiopulmonary bypass and its relationship to AKI. And this is a study from Horig and colleagues at Johns Hopkins. And I just point out to you that the urine, that again, the area under the curve for the lower limit of autoregulation for cerebral blood flow is a highly diagnostic test for determining the situation for AKI, because the kidney, in a sense, thinks somewhat like the brain. Maybe not exactly, but it does have an autoregulation threshold, as we talked about. And then urine flow, it turns out in this study, a urine flow of less than 1.5 ml per kilo per hour was highly significant. So urine flow and this cerebral autoregulation is a very important point. And so that does take technology to do it. Now, the question is, how would we measure minute-to-minute urine output? Now, you may know that there have been devices available, but if you look at the technology in a cardiac surgery unit, this is what you see. Take a look at that technology. You are all very much aware of that. And, you know, you have the ventilator, you have the ECMO systems, you have dialysis, you have all the ventilator, the whole thing. This is how we're measuring urine output in the 21st century. And it's remarkable. So that clearly we need a device to really measure it. And we need to move to the 21st century. And the directions for technology development are, we need an electronic measurement. We need integration of the monitoring data into the electronic medical record, the electronic clinical data systems in the operating room and intensive care units, and we need an alert system. So this is truly an important area for innovative technology. And we had an experience with the UrinFlow device connected to over 50 patients. System worked well. The nurses, of course, appreciated not having to write down all the data and enter it, so that was very well received. This is that device, and we had, as I say, experienced in 50 patients. This is a new device that we created at Johns Hopkins with the master's students of the School of Biomedical Engineering. And so that, we believe that's going to be important. Now, I'm just going to finally finish up. As I mentioned, we have a focus on acute kidney stress, because the real challenge is, how do we detect the environment when the kidney is in danger of being injured? How do we know that? And so the acute kidney stress is a term to about the clinical phase preceding acute kidney injury. And as you know, Dr. Ronco and I have an editorial in Critical Care about this. And it's based on the evolution in the molecular diagnosis because of the renal biomarkers, the cell cycle arrest biomarkers. You know, these cell cycle arrest biomarkers are released along a path which may lead, not always, but may lead to acute kidney injury. And so that is, in a sense, a pre-injury phase and gives us a chance to look at the kidney under stress. So it's proposed that this pre-injury phase, where the kidney is in an unfavorable environment, be called acute kidney stress. And we believe that if we can develop the diagnostic criteria, it could lead early detection and, most importantly, implementation of corrective measurements. So, frankly, it's premature to define criteria for a diagnostic scoring system, although it's very tempting to be working on this, and we are working on this. And we could, in fact, modify some of the classical criteria for AKI. So as we move forward, we want to think about that as an option, but we also have other technological ways to do this. We can look at minute-to-minute urine output, changes in renal cell function, the biomarkers, as we've talked about. So, as I say, it's premature to define the criteria. However, we can start to identify at least parameters. So if you think about the technology I've talked about, what are the parameters? And we can then talk about specific criteria. Well, we've looked at blood pressure. That's a parameter that seems to be useful. Urine output, oxygen delivery, and renal biomarker elevations. Now, why are these parameters particularly attractive? It's because they're available in every intensive care unit, and should be. You know, you don't need to, blood pressure is readily available, urine output should be, and the means to measure it minute to minute should be. Oxygen delivery, we've talked about, we have minimally invasive ways to measure cardiac output, and on cardiopulmonary bypass, we know what the flow is, and then we have the new cell cycle arrest biomarkers and others to guide us. So here are examples of criteria. We could look at blood pressure, for example, mean arterial pressure minus central venous pressure. We could look at urine output criteria, such as urine output over 6 hours or urine output over 15 minutes. We could look at oxygen delivery. We could look at the renal biomarker elevations. And then, if we detect it, you see, we could also incidentally look at measuring real-time glomerular filtration rate. This is technology coming, and technology maybe to measure renal blood flow. I've talked about it to measure minute-to-minute urine output. And then early interventions for AKS, we can use goal-directed hemodynamic management. We can adjust the arterial perfusion pressure, the gradient across the kidney, cardiac output. We can use mechanical circulatory support, VADs or ECMO, and we can decrease vasoconstrictors. We can institute early renal replacement therapy. As you know, we have data now that suggests that early institution can improve the overall outcome. We want to DC any toxic pharmaceuticals, and we may be able to add agents to decrease inflammation and decrease edema. Well, thank you very much. It's a pleasure to talk with you and look forward to our further discussions.